Good morning. Thank you, Sages, for allowing us to present today. To begin, the adrenal gland is often a site of metastases for many different malignancies, and this is probably likely due to the diverse blood supply. The incidence of the metastasis has been quoted to be 3 to 30%, and this range is likely a wide range because this scenario can be diagnosed either upon surveillance of the patient to be clinically symptomatic or post-mortem. The role of adrenal metastasectomy is not well established, and in a patient with clinically isolated adrenal metastasis, this can be a big dilemma for the patient as well as the clinician, especially as this is often a sign of widespread metastasis. The treatment options include observation, chemotherapy, radiation, radiofrequency ablation, and resection. But in the literature, the overall survival has been shown to demonstrate that resection does improve survival versus other treatment. This approach has been done laparoscopically as well as open. And in regards to the oncological outcomes, the differences have been fairly equivalent in the literature, but there's relatively limited data, and we also wanted to focus on the impact of the adjuvant treatment of the patient after the resection of their metastasis. In regards to our objectives today, we wanted to further expand on the benefits of adrenalectomy in regards to clinically isolated metastasis, to demonstrate that surgery is potentially curative, as well as allowing the patient to need no further treatment. We also wanted to compare outcomes between laparoscopic and open resections. So, with IRB approval, we did a retrospective review of our institutional patients who underwent metastasectomy, and we looked at a time frame of 1997 to 2013. In regards to our outcomes, we focused on the size of the tumor on preoperative imaging, as well as dimensions reported by the pathologist, margin status, operative time, as well as length of stay. Post-operative adjuvant therapy was also evaluated in the patients following their resection within a year. The data was analyzed using the Mann-Whitney U test and survival calculated with Kaplan-Meier curve. So after exclusion criteria was applied, we had 38 patients in which 21 underwent laparoscopic adrenalectomy and 17 underwent open. In our laparoscopic patients, 3 did need to have conversion to open, but the data from this patient was still placed under the laparoscopic to which they were intended to have. Our groups were fairly similar. The patients, in regards to the number in each group, had no statistical difference. The age of the both groups were again similar, as well as their gender. But interestingly, the metastasis trended to favor the left side versus the right, but again, no statistical difference between two groups. This pie chart shows the type of disease from the primary malignancy and where our metastasis had come from. In regards to the most likely place of our patient population, the lung was about 52% of our metastases. So in regards to results, we found that the negative margins of laparoscopic versus open were actually non-significant, again showing that laparoscopic adrenalectomy does not compromise oncological outcomes. But in regards to the size of the tumor on pre-op imaging, as well as the dimensions reported by the pathologist, open cases did trend to have larger adrenal lesions. In regards to operative time, they were fairly equal in regards to the numbers listed here, 159 minutes for laparoscopic and 165 minutes for open, as well as the complications with no significant difference. But patients who underwent laparoscopic adrenalectomy actually seemed to recover quicker and trended to stay in the hospital for less days, 3 days compared to 4 in the open adrenalectomies. Following the patients after the resection, we looked at the chemotherapy and radiation administered, and we found in the laparoscopic group, 33% did not require further chemotherapy in the lap, 41 did not require it in the open, and in regards to radiation, 81% did not require it in the laparoscopic group, and 70 did not require it in the open. Overall, our follow-up ranged from 1 to 168 months with the mean listed above or below. Our survival curve is here, showing laparoscopic versus open with a mean of 108 versus 95. So overall, our conclusions show that adrenal metastasectomy does provide good oncological benefits, with 37% of our patients not requiring adjuvant therapy for at least a year. Compared to open, laparoscopic does lead to equal cancer-related outcomes and possibly short-term benefits with better length of stay. Thank you very much.
Questions for this paper? I do have one question. I noticed that the maximum tumor size in the abstract that you submitted was 2.7 for laparoscopic, 4.6 for open, and that was significantly different. I noticed, so is this, you had additional data in here and that's why that difference went away?
Yes, so with our initial abstract submitted, we actually decided to exclude retroperitoneal approach to better define our two groups, because we decided retroperitoneal laparoscopic versus open, it was kind of in the middle. And so in regards to that, we removed that, but then we also extended our date to 2013, so we were able to actually have the same number of patients, but the change in the adrenal size did change our statistics.
Okay, and that's retroperitoneal open and laparoscopic, or just open?
So we excluded all retroperitoneal approaches.
In the completion data?
Correct.
Okay, all right. Are there questions from the audience? I don't believe we have any web questions still, so. And again, a reminder, you can text your questions in. We still don't know what time lunch is, however. All right, thank you very much.